So good morning, dear colleagues in this room and also those of you watching online. Thank you so much for joining us today. This will be a detailed session on the focused update of the 2019 ESC-EAS dyslipidemia guidelines. We want to stress that this is a focused update, so we needed to focus only on the most compelling evidence that was published since the publication of the last main guideline document, and a full guideline update is expected in the next years.
Well, thank you very much for joining us in such huge numbers. So that also shows that dyslipidemia is really a topic that's interesting for a wide audience. We are here on, this was a guideline on behalf of the ESC and EAS, and it's now available, published in European Heart Journal and Atherosclerosis.
Good morning from my side. Hola. Welcome to this session. You seem very interested in dyslipidemia. And I would like also to inform you that there will be a session this afternoon where you can, and hopefully you would ask questions to the experts, to the members of the task force. This will be at 5:30 across on the Damascus room. And there is also tomorrow a session about guidelines in practice with clinical cases. It's my pleasure now to ask the first speaker, my friend Kostas Konstantinos from Bern, who will give his talks about what is new regarding the cardiovascular risk assessment. Please, Kostas.
Yes, thank you very much, Francois. These are my disclosures, and as Janine mentioned, the document is now co-published in both journals. So we will start with the new recommendations in the important field of cardiovascular risk estimation. As you can see, one of the changes compared to the 2019 guideline is the use of SCORE2 and SCORE2-OP instead of SCORE as an algorithm to estimate the 10-year fatal and non-fatal risk in apparently healthy patients without known or established CVD. SCORE2 is newer, it is well validated, it has advantages compared to SCORE, it can estimate risk also in older people, and importantly, it can estimate the risk of not only fatal but also non-fatal events. It is calculated easily using readily available variables including age, sex, non-HDL cholesterol, systolic blood pressure, smoking status, and also geographic region. It is not new in the ESC guidelines overall. It was also recommended, as a reminder, in the ESC prevention guidelines published 4 years ago, but now this is a new addition in our dyslipidemia guideline update. This new definition, among others, has also led to some changes in the classification of risk categories. Here you can see, as a reminder, the categorization according to the 2019 guideline. We've highlighted in red color some of the terms and aspects that have been changed. More specifically now, in the focused update, you will see some changes specifically in the category of very high risk. More importantly, we've partly revised the definition of documented ASCVD by imaging. You will notice now that we have removed the previous quantitative definition and we refer to significant plaque on coronary angiography or CT scan. Importantly, we have also added this new aspect of markedly elevated CAC score by CT. We have refrained from using specific cutoffs in this summary table, but you will read about details in our text referring to the evidence, the newer evidence that is available. Now, across the categories, including the very high, moderate, and low risk, you will also see some new definitions based on new cutoffs and ranges of either SCORE or SCORE2-OP. A second set of new recommendations refers to what we call the risk modifiers. There are two important aspects that need to be kept in mind when discussing risk categories. First, we all know from evidence and also from our own clinical experience that there is vast heterogeneity in risk within each of these risk categories. And secondly, although improved compared to previous versions, neither the SCORE2 nor any of the other algorithms endorsed by other societies can capture the totality of factors that have been proven to significantly affect cardiovascular risk. And this is why we consider these two new recommendations very important. You can see that they are two class 2A recommendations. They should be considered, and they refer to either imaging-based or clinical factors to be used as risk modifiers to improve risk classification. To become a bit more specific, if we have a relatively young, non-diabetic person who is at moderate risk according to our calculations based on SCORE2, and if we also happen to find out that this person has plaque on his coronary arteries, then we think it is reasonable to reclassify this person at a high risk category and then adapt the treatment decisions accordingly. On the left side, you can here see what we recommended in the 2019 guideline, and you can see a class 2A recommendation on the presence of arterial plaque, and also a class 2B recommendation regarding CAC score. The first recommendation has remained unchanged, still a class 2A recommendation, whereas the second one has been revised. It has been updated to a class 2A, and also by including now the presence of significant subclinical coronary atherosclerosis in addition to increased calcium score. Regarding the new recommendation based on clinical factors, you can see in this table a detailed list of all those demographic and clinical conditions, as well as biomarkers, which we now propose to be used potentially as risk modifiers when present. Regarding biomarkers specifically, you can see that we have included hsCRP and also elevated LPA. The reason for this new recommendation and also the evidence behind it was significant in the last years. You can see only some of the examples of studies published recently. Here's one of the studies showing that risk classification and prediction can be improved on top of the estimation based on SCORE2 using different clinical conditions and biomarkers. Now, regarding imaging, specifically the CAC score, also in the last years we have had significant new evidence showing exactly that in people without known cardiovascular disease, the presence of an elevated CAC score significantly improves cardiovascular prognosis and has also been associated actually with increased mortality. This is one of many important recent studies published in the last years, and it shows in a large cohort of almost 6,000 asymptomatic adults with a mean age of around 69, that both the presence of arterial plaque in the carotid arteries and increased calcium score by CT were associated with increased mortality. You can see on the left side the increased mortality across different tertiles of CAC score, and on the right side you can also appreciate that both parameters measured at baseline, both the presence of peripheral carotid plaque and increased CAC score in the coronary arteries, performed comparably as it compares to the risk, the 10-year risk of having events or mortality. Another important study, published also recently, assessed the risk of events calculated as a function of CAC score. It was also a large cohort with a mean age of around 69 years, with a follow-up of around 13 years. And you can see here that compared to people with a CAC score of 0, already at values around 100, you can see a double high risk of having events, and as the CAC score increases, so does the risk of having MACE in the subsequent years. Regarding treatment goals for LDL cholesterol, these have not been changed in this focused update. You can see, again, that the treatment goal is directly related to the level of total cardiovascular risk. The only change or addition in this summary figure is the addition of what we have called extreme risk, and in these patients there is a recommendation for an even lower treatment goal of below 1 millimole per liter or below 40 milligrams per deciliter, and this is a class 2B recommendation which is aligned with the 2019 guidelines. Treatment goals are very important, but we think that an equally important question is when to recommend, when to start pharmacologic LDL-lowering therapy in persons, specifically in primary prevention, that is, those without already known cardiovascular disease. In the 2019 guidelines, we provided guidance that is summarized in this figure. However, we did not include specific recommendations in this respect. In this focused update, we have added 2 new recommendations. The question being, when should drug therapy be started in persons at different levels of risk with different LDL levels, or again in the setting of primary prevention, that is, in persons without known cardiovascular disease. You can see a stronger class 1 recommendation and also a class 2A recommendation in relation to the class of risk and the LDL-C levels. As my co-chair reminded, this is the main session. We will have also additional sessions. Tomorrow at 5:30, today at 5:30, you will have the Ask the Task Force session, and also tomorrow you will have the Guidelines in Practice session, and we all kindly ask you to please join us, ask your questions, and we'll make sure that we address as many of them as we can. And then following these presentations in the Congress, we have also prepared a series of webinars where we'll hopefully provide more details about what we have presented in these guidelines. Thank you very much.
Thank you very much, Kostas. And then we'll go to the next presentation by Lala Tokozoglu, who also served as coordinator for this guideline, and she will talk about what's new on Lp(a) in this focused update.
Thank you very much, Janine. Here you can see my disclosures.
Yes.
Lipoprotein a is a genetically determined and a prevalent risk factor for atherosclerotic cardiovascular disease as well as aortic stenosis. Elevated Lp(a) is not a rare disease. The estimated prevalence globally is thought to be around 20%, more so in Africa and less in East Asia. Lipoprotein a is mostly determined genetically and by ethnicity, but certain medical conditions such as kidney liver disease, hormones, and inflammation can also alter Lp(a) levels. Lp(a) was first mentioned in the 2019 ESC/EAS guidelines as a risk enhancer, but since then, major accumulation of information has prompted a consensus paper from the European Atherosclerosis Society as well as the NLA, leading to information about the new guidelines. The first question is, when should Lp(a) be measured? The 2019 recommendations base their data on Mendelian randomization from 5 studies with external validation. And at that time, we recommended that individuals with very high Lp(a) levels, above 180 milligrams per deciliter or above 430 nanomole per liter, have a lifetime atherosclerotic vascular disease risk that is equal to untreated heterozygous familial hypercholesterolemia, as you see here. So for this reason, the recommendation said that Lp(a) measurement should be considered at least once in each adult's lifetime to identify these very high-risk patients, and should be considered in selected patients with a family history of early cardiovascular disease and for reclassification in people who are borderline between moderate and high risk. Since then, important information has accumulated, and here you see the analysis from the UK Biobank in about 500,000 individuals, showing that there is not a threshold. There is a linear rise in atherosclerotic vascular disease risk with increasing Lp(a) concentrations, showing that the relationship is continuous, and in secondary prevention, very high Lp levels increase the risk of disease. There's also data from epidemiology showing that cardiovascular disease risk increases with increasing Lp(a) concentrations. And here is data from the Copenhagen general population showing that above the 75th percentile, aortic valve stenosis myocardial infarction risk increases. Above the 90th percentile, heart failure, and above 95 percentile, cardiovascular mortality and ischemic stroke risk increase. There is also evidence from Mendelian randomization trials suggesting that per particle, Lp(a) may be more atherogenic than LDL cholesterol because of its pro-inflammatory and possible antifibrinolytic properties. Usually, in most people, there's more circulating LDL cholesterol. So, in 2025, who should be screened for Lp(a), taking all this information into consideration? We have not changed the recommendation from 2019 that Lp(a) measurement should be considered at least once in each adult person's lifetime, preferably at the first lipid panel. We also emphasize that screening is relevant in younger patients with familial hypercholesterolemia, early atherosclerotic vascular disease, no identifiable risk factors, family history of premature ACVD or high Lp(a) levels, and individuals at moderate risk or around treatment decision thresholds to improve risk classification. There is also a new recommendation that after menopause, a second measurement is reasonable, especially in women whose premenopausal Lp(a) levels were borderline. So what is the new definition of high Lp(a)? Here you see the skewed distribution of lipoprotein a in Europe in white individuals. And here you see the increasing lifetime risk for major cardiovascular events. So risk from high Lp(a) increases slightly after 30 milligrams per deciliter or 62 nanomole per liter to 50, and becomes clinically relevant above 50 milligrams per deciliter or 105 nanomole per liter, with higher levels associated with a greater increase in risk, thus leading to the recommendation that Lp(a) levels above 50 milligrams per deciliter or 105 nanomole per liter should be considered in all adults as a risk enhancer with higher levels associated with greater risk. We also acknowledge the challenges with Lp(a) measurement in the new guideline because there's substantial variability among different assays relating to apolil(a) structure, variability in the Kringle-4 repeats, potentially under or overestimating Lp(a) levels. So we recommend measurement in molar units, which is nanomole per liter. However, mass units, milligram per deciliter, can be used for clinical purposes, knowing that nanomole per liter may not be available everywhere. How does elevated Lp(a) contribute to risk assessment? Well, the previous approach was that it only marginally improves risk discrimination because of the skewed distribution. But the new approach is to estimate how much the Lp(a) increases the individual's overall risk, taking into account not only the Lp(a) levels, but the baseline absolute global risk of the patient. Here you see the baseline risk categories looking at traditional risk factors. And here you see the additional risk above the estimated baseline risk by the respective Lp(a) concentration categories. So if Lp(a) levels are not considered, the absolute risk might be underestimated substantially. Let's say you have an Lp(a) of 115 nanomole per liter, which will increase your risk 1.4-fold, but with 350 nanomole per liter, the risk will increase 2.7-fold. There is a reference risk calculator in the guideline showing first the lifetime risk predicted, estimated by conventional risk factors, and how much it will increase if your Lp(a) is increased. New publications have confirmed that high Lp(a) contributes to lifetime cardiovascular risk. And here on the left-hand side, you see data from the Women's Health Study showing that the highest quintile of Lp(a) shows significant increase in risk in US women. And this has been validated in European individuals, both men and women, in the EPIC Norfolk study. So how do we incorporate Lp(a) into clinical decision-making to mitigate the risk? First of all, we need more intensive classical risk factor management with increasing Lp(a) concentrations and increasing baseline risk, so that at least we will be able to alter the baseline risk. When we look at the effect of interventions, lifestyle unfortunately does not affect Lp(a) levels. High-intensity statins do not change it significantly, although small trials suggest small increases. Ezetimibe, bempedoic acid do not change it. PCSK9 inhibitors decrease it by 25%, and so does niacin, but no clinical benefit there. And obicetrapib is thought to decrease it by 30 to 50%. We need to see the outcome trials, where apheresis is really effective, but we are eagerly waiting for specific Lp(a) lowering therapies. Because of the questions about statins increasing Lp(a), a large meta-analysis was performed in 39 randomized trials showing that statin therapy does not lead to clinically important differences in Lp(a) compared to placebo. How should we approach our patient in the absence of specific Lp(a) lowering therapies is answered by early risk factor management and much more intensive LDL cholesterol lowering, considering both the absolute cardiovascular risk and Lp(a) levels. There are several specific Lp(a) lowering medications being tested in randomized clinical trials, which will lower Lp(a) levels effectively, going up to 98%. Both oral and injectables are on the way. But we still have gaps in knowledge. Will lowering Lp(a) reduce the risk of atherosclerotic vascular disease and aortic valve stenosis progression? And what is the extent of Lp(a) lowering required for clinical benefit? Because Mendelian randomization trials are suggesting different numbers for 22% relative risk reductions. The genetic estimates vary from 66 to 101 milligram deciliter reduction required. So in conclusion, we acknowledge that there is a continuous association between high plasma Lp(a) levels and higher risk of atherosclerotic vascular disease, as well as aortic stenosis. Although the risk is continuous, the new cutoff level for practical clinical purposes is that Lp(a) levels above 50 milligrams per deciliter or 105 nanomole per liter should be considered in all adults as a cardiovascular risk enhancing factor, with higher Lp(a) levels associated with a greater increase in risk. And in the absence of specific Lp(a) lowering therapies, and we hope to get some results next year, early risk factor management and more intensive LDL cholesterol lowering is recommended, where we consider both the patient's absolute cardiovascular risk, preferably lifetime risk, and Lp(a) levels. Thank you for your attention.
Thank you very much, Lara. That was extraordinary. Thank you so much. Now, the next topic is on drugs. Actually, in the last years, we did have evidence on new lipid-lowering drugs and combinations. And we have the honor and pleasure of having Professor Ulf Landmesser from Berlin, Germany, as part of this task force. And he will be presenting an update on LDL-lowering drugs and combinations. Ulf, thank you so much.
Thank you so much. It's a great pleasure to provide you an update based on the focused guideline update regarding LDL-lowering drugs and combinations, one of our major pillars in the prevention of development and progression of atherosclerotic cardiovascular diseases that are still the main cause of death in our populations. I want to divide the presentation in first updating you on new recommendations for LDL cholesterol-lowering therapies, and then we have in this focused update some specific recommendations for patient populations, patients with an acute coronary syndrome, patients who are having cancer and are treated with a very high chemotherapy-related cardiovascular toxicity risk that we want to protect, and also people with HIV injection for whom we have new data and we know they are at increased risk of atherosclerotic cardiovascular diseases. We have actually, as I'm sure you are very well aware of, a fourth evidence-based therapy that lowers LDL and can improve cardiovascular outcomes beyond statins, ezetimibe, and PCSK9 inhibition, and this is bempedoic acid. And as you see here in this nice illustration from the New England Journal, that the drug is a prodrug and needs to be activated, and this activation is dependent on an enzyme in the hepatocyte. So it was specifically the idea not to have activation in the muscle cells in order to avoid muscle-related problems. We have for bempedoic acid, in the meantime, after the last guideline publication, the CLEAR Outcomes trial, and in the CLEAR Outcomes trial, specifically statin-intolerant patients considered intolerant by both their physicians as well as the patient perspective, and these patients were treated with bempedoic acid, and the trial could show efficacy regarding improved cardiovascular outcomes that you see in both of these slides, and there were no relevant safety problems. So clearly that's a new therapy that we need to consider in the guidelines. So the first statement in the guidelines is that non-statin therapies with proven cardiovascular benefit taken alone or in combination are recommended for patients who are unable to take statin therapy to lower their LDL levels. We also want to protect these patients, and as you probably know, statin intolerant patients are more frequently women, so we specifically address here that we want to also have effective protection from atherosclerotic cardiovascular diseases in these patients. There's a specific recommendation based on the new trial evidence for bempedoic acid that's recommended in patients who are unable to take statin therapy to achieve their LDL goal. You see, this is a 1B recommendation because we have one large outcome trial in this specific patient population of statin intolerant patients. In the guideline, you will find this very nice figure where actually the impact that can on average be achieved on LDL lowering is depicted. And you see there's now the addition here of bempedoic acid and also the combination of ezetimibe and bempedoic acid that's actually frequently used now in clinical practice because it comes close to what we achieve with statin therapy for these patients who are actually not able to tolerate statin therapy. There is in the focused update now also a recommendation on patients that are on statin therapy and not reaching goal, and here bempedoic acid can be considered as an addition for LDL lowering. You see this is a 2AC recommendation. C means we have no trial evidence for the specifically clinical outcomes in addition to statin therapy. However, we do know there is LDL lowering by bempedoic acid in addition to statin therapy. This is also depicted here in the figure where you can see actually the impact that can be expected on average for addition of these bempedoic acid or also ezetimibe and bempedoic acid in patients who are on statin therapy. Now I come to the specific patient populations, and as you know, patients with an acute coronary syndrome are a particular high-risk patient population for atherosclerotic cardiovascular disease-related events. Therefore, we really want to promote protection for these patients as good as possible, and we have therefore added here in the guideline update a statement that intensification of lipid-lowering therapy is recommended in patients who are hospitalized for an acute coronary syndrome, and a second recommendation that actually in patients who are treatment naive regarding lipid lowering, we do recommend now that the combination of intense statin therapy with ezetimibe is already started in these patients if statins alone are not expected to bring the patient to the LDL target. We just want to speed up the process of lowering LDL cholesterol because we know that also the time is relevant, and the earlier we get the LDL cholesterol into the recommended treatment goals, the better it will be for the patients. There's another new recommendation specifically for patients with cancer who are treated with chemotherapy that has a related very high cardiovascular risk. This is in particular anthracycline-based chemotherapy, and there have been, after the last guideline, 4 clinical studies suggesting actually benefit of statin therapy to protect from cardiotoxicity in this quite frequently used anthracycline-based chemotherapy. So therefore, based on these new studies, there is a recommendation that statins should be considered in adult patients at high or very high risk for developing chemotherapy-related cardiovascular toxicity. That's a new recommendation in this dyslipidemia guideline, consistent also with the cardio-oncology. Finally, there is also the clear observation that people with HIV infection are at increased risk of atherosclerotic cardiovascular disease. And after the last guideline, there was a large clinical trial, the REPRIVE study, that actually randomized more than 7,000 people with HIV infection to statin therapy or placebo. And you can see here on the right side the quite impressive protection from major adverse cardiovascular events in these HIV infected people, and therefore the task force gave a strong recommendation of statin therapy in people with HIV infection above 40 years. These were the inclusion criteria of the study that I just presented to you in order to protect them from development or progression of atherosclerotic cardiovascular disease. It's a B recommendation because we have now one large clinical trial. And by that, I thank you very much for your kind attention.
Thank you all for a very clear presentation. Again, it's my great pleasure to introduce Marianne Bean from Denmark. She will give us 2 topics, one on triglyceride. You may have heard yesterday and read on the New England that there are new powerful therapies to massively reduce triglyceride. And also the second topic will be also on concern about nutraceuticals. Please, Marianne, the podium is yours.
Thank you, Francois. These are my disclosures, if I can activate this thing. Sorry. When we measure triglycerides, we measure the triglyceride content in the particles that contain them, shown here on this slide, with triglycerides in blue and cholesterol in yellow. Some particles are more triglyceride rich than others. These are the chylomicrons, the chylomicron remnants, VLDL and VLDL remnants. In the fasting state, there are no chylomicrons, so the triglyceride-rich lipoproteins are the remnants, the VLDL and the VLDL remnants. So when we measure triglyceride in the fasting state, we measure the amount of triglycerides in the cholesterol-containing remnant particles. Triglyceride levels are considered normal when they're below 1.5, elevated between 1.5 and 2.3, and hypertriglyceridemia when above 2.3, and severe hypertriglyceridemia when above 8.5 millimolar per liter. Common causes of hypertriglyceridemia are high alcohol intake, overweight and obesity, metabolic syndrome, type 2 diabetes, physical inactivity, and an unhealthy diet. Severe hypertriglyceridemia is most often caused by multigenic and monogenic diseases. It is well known that triglyceride concentrations are associated with cardiovascular risk. This is known for ASCVD and MACE, and shown here for all-cause mortality and cardiovascular mortality. As you see on the left panel, triglyceride all-cause mortality risk increases with increasing triglyceride concentration, and it is significant at a level above 0.8 millimolar per liter. For this reason, the 2019 guideline had some suggestions for lifestyle modifications to reduce triglyceride-rich lipoprotein levels. These are still valid and are: reduce excessive body weight, reduce alcohol intake, increase physical activity, reduce total amount of dietary carbohydrates, reduce intake of mono and disaccharides, replace saturated fats with mono and polyunsaturated fats. In addition to these lifestyle modifications, some of the LDL lowering drugs and other drugs also reduce triglyceride concentration. Shown on this graph is the average triglyceride reduction in percent for various drugs. Those shown in green have shown cardiovascular benefits, those in blue, no cardiovascular benefits, and the one in purple reduces risk of pancreatitis. As you can see, statins reduce triglycerides by 15 to 20%. There's also a reduction for ezetimibe plus statin, and PCSK9 inhibitors. The reduction seen for statins formed the basis for the 2019 guideline recommendation. Statin treatment is recommended as the first drug of choice to reduce cardiovascular risk in high-risk individuals with hypertriglyceridemia. And this recommendation is still valid, and it is central to the reduction of triglycerides. There's also a 44% reduction in triglycerides for bezafibrate and fenofibrate, and a 26% reduction for pemafibrate, although none of the fibrates have shown any cardiovascular benefits. Pemafibrate in the prominent study increased LDL cholesterol and apolipoprotein B slightly, and for this reason, the current guideline recommend bezafibrate and fenofibrate in addition to statins in individuals with high risk with hypertriglyceridemia. At the time of the 2019 guideline, the REDUCE IT trial had been published showing a 20% reduction in triglycerides and a 25% reduction in MACE using icosapent ethyl. Since then, two other studies, the STRENGTH and the OMEBI trial, have been published. They also reduce triglyceride levels, but they have no cardiovascular benefits. I'll just show you some data from these studies. Shown here, the REDUCE IT on the left hand and STRENGTH on the right. They were both randomized clinical trials in relatively high-risk patients with hypertriglyceridemia. Both reduced triglycerides by around 20%. The REDUCE IT trial reduced cardiovascular risk, or MACE, by 25%, and in the STRENGTH trial, there was absolutely no indication of a risk reduction. These findings have been discussed intensively, and there are some differences between the studies. For example, the active drug used in REDUCE IT was icosapent ethyl, which is a purified EPA ethyl ester, while the drug in the STRENGTH study was a mix of EPA and DHA. There was also differences in the comparators used. I'll not go into detail with that. But because of these findings, the updated guidelines specifically recommend use of icosapent ethyl as used in the strength trial. In support of this, data from the OMIMI trial show similar findings to the strength trial. You can see here the OMIMI trial is a little different. It is a smaller study in elderly with a recent myocardial infarction and not having hypertriglyceridemia. There was a 13% reduction in triglycerides, but absolutely no effect on MACE within 2 years and all-cause mortality. This study used the same active drug as used in the strength, but in a lower dose. Also, since the 2019 guideline, the approach study had been published showing a 77% reduction in triglycerides in people with hypertriglyceridemia or severe hypertriglyceridemia due to familial chylomicronemia syndrome. So this forms the basis for recommending use of volanesorsen in individuals with severe hypertriglyceridemia with familial chylomicronemia. There's no reduction in cardiovascular risk, but there is a meta-analysis of 3 studies of volanesorsen showing a reduction in risk of pancreatitis. Volanesorsen is approved in Europe, but not yet in the US. So this brings me to the summary of the recommendations for triglycerides. Statin treatment is recommended as the first drug of choice to reduce cardiovascular risk in high-risk individuals with hypertriglyceridemia. In primary prevention patients and in high-risk patients who are at LDL cholesterol goal with triglyceride levels above 2.3 millimolar per liter, fenofibrate or bezafibrate may be considered in combination with statins. And from the updated guideline, high-dose icosapent ethyl should be considered in combination with a statin in high-risk or very high-risk patients with elevated triglyceride levels to reduce the risk of cardiovascular events. Volanesorsen should be considered in patients with severe hypertriglyceridemia due to familial chylomicronemia syndrome to lower triglyceride levels and reduce risk of pancreatitis. This brings me to the recommendations regarding nutraceuticals. In the 2019 guideline, there was an extensive chapter on food choices to reduce LDL cholesterol concentrations and improve the overall lipid profile. These recommendations on diet remain the same, but there are new updated recommendations on dietary supplements. These are due to the study findings on the omega-3 trials and a new study, the SPORT study, and a warning from the European Union. First, the SPORT study. The SPORT study was a randomized clinical trial examining supplements, placebo, and rosuvastatin. It is patients with no prior ASCVD, but with elevated 10-year risk and an LDL cholesterol between 1.8 and 4.9 millimolar per liter. The primary endpoint was % change in LDL cholesterol at 28 days. At the follow-up, there was a 38% reduction in LDL cholesterol and a 19% reduction in triglycerides for rosuvastatin, but there was absolutely no effect of fish oil, cinnamon, garlic, turmeric, plant sterols, or red yeast rice compared to placebo. In 2022, the European Union issued a warning on the monacolins from red yeast rice. So the new updated guideline recommends that dietary supplements of vitamins without documented safety and significant LDL cholesterol lowering efficacy are not recommended to lower the risk of ASCVD. Thank you for your interest in these guidelines, and also please come to the task force question this afternoon and the guideline in practice tomorrow. Thank you.
Thank you, Marianne, for this elegant and very precise presentation. On behalf of my co-chair, I would like to thank all the speakers for their presentation, and as a Swiss perspective, also for keeping the time. We are really on time, and we would like to thank you for attending this session, either on site or online. We wish you, of course, a good continuation of the Congress and a bon appetit with an adapted amount of lipids. Thank you very much. Thank you.